Greetings. I'm Dr. Emilio Mateo. It is an honor to participate in one of the websites of continuing education that is highly recognized worldwide, Dental XP. I appreciate the support of Dr. Marisa Lama and Dr. Alvaro Ordóñez. The topic to cover is plastic periodontic surgery with altered passive eruption with the use of electrosurgery. For this, it is important to review three important topics of the periodontal surgery. The first one of them is the smile stages. Like Kamara mentioned in 2010, there are two types. The social smile, that is when the upper lip elevates towards the nasolabial sulcus, and the spontaneous smile, that is when there is a higher elevation of the upper lip and the nasolabial sulcus. This brings as a consequence that the eyes look somewhat closed, which represents the contraction of the periocular muscles, as you can see in the images. The second topic is the smile line, which Miller classified in mid-80s in three categories, as high smile line, middle smile line, and low smile line. This states that for a high smile line, there should be more than 3 millimeters of gingival display. For middle smile line, about 1 to 3 millimeters of gingival smile and 100% of tooth exposure. And for low smile line, only 75% of tooth exposure. It is important what Dr. Stephen Chu and Dr. Tarnell have established in 2012, that we should not leave undiagnosed the interdental papillus in the dynamic smile, because this can show in a high percentage of patients and also represents an important aesthetic element. The third aspect to cover is the proportions in the aesthetic zone, where David Garber and Marisa Lama in 2006 indicate that the gingival margin of the upper incisors should be located approximately at the same height as the canines, and the lateral incisors slightly of 1 to 1.5 millimeters. The gingival zenith in the upper central incisors and canines is slightly offset to the distal, but centered in the lateral incisors, as you can appreciate in the image. For the exact measurements of the golden proportions, Dr. Shu in 2007 created the T-shaped ruler, an innovative idea for the aesthetic crown lengthening designed to measure the width and height of the maxillary anterior teeth simultaneously, utilizing measuring indicators for predictable surgical results and establishing new diagnostic and treatment standards in the aesthetic zone. This instrument is coded with collars with a pre-established index of approximated width and height. A band of a particular color of the vertical arm corresponds to the same color band of the horizontal arm placed over the teeth. The main objective is to ensure that the tooth is proportioned. Finally, it is an aesthetic treatment that entails the associated needs with the changes in tooth size, shape, proportion, and balance, and can influence negatively the smile appearance. In periodontal plastic surgeries, it is very important to know the biological space, that it's defined as Gargiulo and Vosek as the dental gingival union of the union epithelium and the gingival connective tissue attachment. When we talk about biological space, we should relate it to the gingival biotype and the depth of the gingival sulcus. In 1994, John Coyce writes that the biological space is approximately 3 millimeters facially and 4.5 to 5 millimeters interproximally. The cases that will be presented are the patients that have smiles with important periodontal and aesthetic implications and require surgical treatment because the gingival margin is incisively badly positioned over the clinical crown and it doesn't approximate towards the CEJ. The process is defined as altered passive eruption. As Dr. Carol Solis mentioned in 2008, to diagnose altered passive eruption, you should place the end of the periodontal probe under the gingival margin, trying to locate the CEJ to determine the anatomic crown length. In the requirements, there should not be any other clinical sign of disease like bleeding on probing, exudate, inflammation, or bone loss. We should also note that passive eruption has been completed as it can continue during adolescence years, and it's because that the treatment is recommended after 20 years of age. We should also evaluate the length of the anatomic and clinical crown, the width of the attached gingiva, the location of the alveolar crest, dental malalignments, presence of diastemas hiding under soft tissue, enamel lesions, periodontal support, the frenum, the level of attachment, and the degree of inflammation. Coslet in 1977 classified altered passive eruption in two types, each of them subdivided in A and B. Type 1A, where there is enough attached gingiva and the mucogingival junction is away from the CEJ. The bone is about 1.5 to 2 millimeters of the CEJ. For this, only a gingivectomy should be done. And the type 1B, different than the 1A, because the bone reaches the CEJ. For this, you should do crown lengthening with osseous surgery. In the type 2A, the mucogingival junction is located at the CEJ, and the bone is 1.5 to 2 millimeters of the CEJ. For this, you should do an apical positioned flap. In the 2B, bone is at the CEJ, so you should do an apical positioned flap with osseous surgery. Altered passive eruption can be accomplished with electrosurgery that, according to Lee Silverstein in 2008, consists of removing layers of gingiva with the end of the electrosurge, performing gingivectomies and gingivoplasties. This allows for an adequate contour of the tissue and controls the hemorrhage due to the immediate coagulation of the small blood vessels and capillaries. Due to this, it allows for an excellent visual control. It uses combined energy for cutting and cauterizing. Its good application will depend on the surgeon's ability and his knowledge to be a good complement for the periodontal plastic surgery. In continuation, we will present 3 clinical cases of periodontal plastic surgeries by means of altered passive eruption. Clinic case 1 is a patient of 22 years of age who decides to go for treatment because he wanted to change his appearance because he displaced an excessive amount of gingiva. Here you can appreciate in a closer look the frontal aesthetics, where we can see a deviation of the left side and the gingival margins of the centrals are very disproportionate, knowing they should be at the same height of the canines. In the surgical sequence, we show the adequate contour of the tissues by the correct use of the electrosurge. Achieving the transformation of the gingival structure with the clean procedure without bleeding, with excellent visual control, and also obtaining a correct aesthetic proportion in the aesthetic zone according to the reference of Dr. Marisa Lama. In this image, you can see the elevation of a mucoperiosteal flap with osteotomy process and osteoplasty. In the immediate post-surgical phase, we place continue vertical matrices, sutures. 8 months later, we project here the before and the after to see the difference. We can see the control and the stability of the results at long term. And observing the great changes in the patient's face before and after the surgical procedure. He reported feeling secure and enthusiastic about his smile, as you can see in the image. In clinical case 2, it's a patient of 22 years of age referred to by her orthodontist. She was in the final stage of the treatment. She complains that her teeth were too small, and this motivated her to have this aesthetic surgery. As you can see in the image, the gingival margin is flat, so it's poorly defined. In this image, we can verify the golden proportions and bone sounding. After the elevation of the mucoperiosteal flap, we can appreciate clearly the altered passive eruption where the alveolar crest is at the CEJ. invading the biological space. So with osteotomy and osteoplasty, we gain back about 2 to 3 millimeters approximately, presenting the adequate festooning of the alveolar crest as it is presented in this image. On the 7th day, still showing a little inflammation of the gingival margin, you can appreciate the change in the gingival architecture. At 2 months, there is a radical and successful change in the anatomics of the aesthetics, as you can see in the image. The frontal improved frontal aesthetics in size, shape, proportion, and balance, letting her show a spontaneous smile. And the last case, it's a patient of 21 years of age who displays an excessive amount of gingiva. She expresses that her teeth are very small and that when she smiles, she shows too much gingiva. For this, she's requesting the treatment, even though there's still a couple of months left on her ortho treatment. In this image, you can see the frontal aesthetics prior to the surgery. With the help of the golden proportions of Dr. Stephen Shu, we measured the vertical and horizontal lengths of the centrals and laterals and canines to ensure the correct proportions of the teeth. Here you can see closer the discrepancy of the centrals with their real size. They present like sizes of small laterals, because they should have found the gingival margin of the central in the superior area of the red band of the vertical arm of the ruler of Chu. In the surgical sequence, we eliminate the soft tissue that is coronal to the CEJ with the electrosurge. And we elevate a mucoperiosteal flap. We can appreciate some exostosis that this patient presents. We proceed with osteotomy and osteoplasty. This is a lateral view from the lower. You can appreciate the osseous festooning of the osseous remodeling. For the immediate post-surgical phase, we suture with vertical mattress sutures, which allows the gingival tissue to remain where we need it. This suture is placed towards the palate due to the fact that the patient has an excessive gingival smile. The post-op, 15 days later, shows like this. Even though she has a slight inflammation, we have achieved a festooned gingival architecture, which improves radically her frontal aesthetics. Her face looks much more attractive in relation to her structure and parameter. Six months later, we maintain the gingival margin in the desired position. 1 year later, with no ortho, the patient shows a substantial improvement in her appearance. It has been a pleasure to be with you. Thank you very much.